I'm Sharon Brett Kelly, and today on The Detail I'm outside Whakatane Hospital. It's a hospital that serves a population of around 38,000 people in a large area of Eastern Bay of Plenty. It has 3 theatres, 160 beds, and employs more than 800 people. If you go onto the website, you'll see there are plenty of jobs here. No surprise there, I guess. Jobs from nurse practitioners to midwife to a psychiatrist. Now, the Whakatane Mayor, Victor Luca, says it's an excellent hospital and serves the community well, and that the community here has fought hard to keep these services. But he's really worried about the future. So I'm off to talk to him to find out why he thinks rampant privatisation of the health service is putting this hospital and the public health services offered in this area under so much threat.
Would you like some water or anything?
No, I'm fine, thank you. Yeah. So I'm sitting in the office of the Whakatane Mayor,
Victor Luca.
And should we declare that we know each other from a long time ago, Victor?
We could, yes. Why not? Makes it more friendly.
Yeah, that's right. We went to primary school together.
Yes, both born and bred here, right?
But you have made contact with me because you're worried about what's going on with our health system.
Absolutely. Not just me.
Yeah, so every day in the news we are hearing something new. We either hear of a sad story of someone who's not getting good treatment. Right. Of all the issues that are going on, what is it about the health system that is getting to you?
I should mention that I'm here speaking on behalf of Victor Luca, the scientist of 30 years, the president of our local Grey Power Association. I'm not representing the views of council. What's my angle? I guess I'm concerned about the privatisation of our health system.
What are you seeing?
I'm seeing an increase in privatisation. I'm seeing that we're trying to copy other systems.
Such as?
The United States of America.
Why is that a bad thing? What's wrong with privatising the health system?
There's a sort of famous graph going around that's a plot of life expectancy versus the amount of money spent as a percentage of GDP. The United States, which is almost a completely privatised system, has got one of the lower life expectancies on average, and yet they spend 2 to 3 times what we do in terms of percentage of GDP. So for me, that's a very clear evidence that private is not necessarily better.
Modern medicine, folks. Very impressive. But that's not the end of your journey. The average cost for the surgery you just had is around $15,000. Now, if you happen to have good health insurance, that'll probably pay for most of it. But if you have bad insurance or no insurance, you're on the hook for paying most of it, or all of it yourself. Not a fun position to be in.
There's over 30 million people who have no health insurance whatsoever.
And a lot of the disparities that we see within the healthcare system in the U.S. are the result of poor economic and environmental conditions.
When you introduce private players, they're there for the profit motive. A lot of them are private capital funds that are getting into the health sector. It's particularly prevalent in the United States, not so much here. But if you look at who's funding laboratories and things like that, you'll see that they are some are pension funds, some are, Canadian funds.
And how do you see that playing out in Whakatane?
In Whakatane, what we have is, I think, a similar sort of thing to what's going on in many parts of the country. I tried to make an appointment with my GP at the end of August and got my appointment for the 4th of October.
You did a bit of a ring around to see when you could get an appointment with a GP in Whakatane, and roughly, a month to 6 weeks?
A month. The previous attempt was more than a month, but I'm trying to see my GP who knows my history. And that's difficult. And I don't think that's anything rare. I mean, in Kawara they say it's quicker to get an undertaker than it is to get a doctor. Poriki, I think, is doing okay because they got a couple of locums who decided they were going to make a poriki home. Whakatane, I've heard that we've got like 16 doctors short. That was one thing.
16?
So it is said. I haven't verified that number, but it wouldn't surprise me.
So if you think about who provides your healthcare right now, you might be surprised at how much is private. Your GP, your dentist, the labs where you get your blood tested, the place you go to get an X-ray. Then there's the surgeons, the specialists. They often work public and private. And even if you go public, you might be sent to a private hospital with more and more surgeries being outsourced. Well, being a scientist of 30 years, Victor Luca wanted proof. He wanted a breakdown of what was public and private, but getting that information was difficult. He started asking the Ministry of Health for the data several years ago.
I've done a lot of Legoima requests.
That's the local
to get
government
data,
official...
So Official Information Act requests.
Yeah.
I asked for all information going back to the start of when we started accounting, and I've got from 2020. One of the things I asked the Ministry of Health for was the business case that proves that privatisation is better, more economically efficient and results in better health outcomes for people. And they said there is no such document, which is quite funny for me because if we have to do anything in council, we have to do a business case. So if private is better, the onus of proof should be on the person or the entity that's making the case that private is better. Well, when I look at that graph of the United States of life expectancy versus percent spent on GDP, it's actually arguing the opposite, and it's very clear.
I think you even call it privatisation by stealth.
Correct.
So are you saying that the people in charge of our health system know that this increase in privatisation is going on and they're allowing it to happen, even encouraging it to happen?
It's my hypothesis is that it's actually being actively encouraged. They responded to me that they are not privatising. So I said, well, okay, I want the evidence. So show me your breakdown public-private. I mean, there are three components to health. One is prevention. That's the thing that's been sort of shunted out of the way. Diagnostics, and then the treatment and cure part. So the whole of the pathology sector is it's pretty well privatised and consolidated because the argument it is that that's better, more economically efficient. I can talk about radiology. And so I also requested under Legoima a full list of all medical imaging modalities.
Which are?
X-ray CT, PET CT, SPECT, and ultrasound scanning. All of those techniques, I can see that parts of that, the level of privatisation is increasing. But that's data that I had to compile manually because when I started this, we had 20-odd DHBs, and the only way I asked the Ministry of Health for a consolidated view of what it was, and they couldn't give it to me. They said you have to ask each individual DHB.
But now there are no DHBs.
That's right. But I was just shocked and horrified that the Ministry of Health couldn't give me those numbers, because if you want to keep your finger on the pulse of what your health system is doing, then you need to have those numbers. And because I have lived in the United States for a couple of years, and their system that's U-Butte is U-Butte for 1 to 10% of the population.
So you're afraid that we're heading down track?
I think we are.
What would that look like in a town like this?
In a town, our district has got a high rate of deprivation. We have decile 9, 10 in parts, and that would be devastating here. Well, we're quite lucky that we managed to retain our hospital in this town. The hospital services a lot of the east coast, the Portakey, Kawerau area, so it's really servicing quite an area, but it could have been taken away with the same ethos of condensing and stripping back services. And our hospital is going from strength to strength. I mean, we've recently had we had a X-ray CT scanner installed a few years ago, and we've just been upgraded, and now an MRI machine is being installed because other than if it's not here, it's centralised in Tauranga.
You're saying it's going from strength to strength. So that doesn't that go against your argument that we're privatising a lot more things and losing health services to bigger centres? What
I'm appraising is the fact that we've got some diagnostics here that we didn't have before. So yeah, we're lucky to have a hospital. But the point I'm making is if the people didn't fight for it, it wouldn't be here.
Yeah.
And things would be much tougher for this community.
So is further privatisation inevitable? Well, not necessarily. Otago University health professor Robin Gould says the current split is 80% of health spending is public, the rest is private. And private is slowly creeping higher.
But then we've got health insurance, and historically about a third of our population have had private health insurance. That has been creeping upwards of late. That private insurance will be funding some of that 20% of the private expenditure that goes on in our economy. And then the rest of that will be coming from co-payments that you and I pay to see the GP. Mostly those aren't covered by private insurance. It will be the pharmaceutical co-payments and then the various other payments that people might make who aren't insured, who perhaps pursue a private option, for example, to get a first specialist assessment when you've been referred for a clinically identified need by your GP. The GP might ask you, and it's fairly common for the GP to ask you, do you have insurance? Yes, no. If you do, let's refer you private because you'll be seen much more quickly. And if the answer is no, the GP might say, are you prepared to pay? Because if you want peace of mind and if you want this dealt with in a timely fashion, it could be considered low priority in the public sector, but we probably can get you seen in the next 2 or 3 weeks privately. So there are those payments coming through as well as part of that 20%.
But is there anything wrong with that?
Well, at the most basic level, we live in a market economy, and in a market economy, people provide goods and services to whoever pays for them. However, health economics are not like mainstream economics, and they should never be conflated with one another. Healthcare markets do not function in the same way in which markets for, say, computers or houses function. Healthcare markets are ones where there is a strong need for government intervention, and that's because of what's called market failure.
Market failure is when the market, left alone, doesn't distribute a service efficiently.
You get market failure in areas like roading, sewage and clean water and so forth. But there's also a lot of government intervention globally in healthcare markets. If you have this assumption that it's actually okay to have a public-private split in your healthcare market, and those who can pay, good on them, and isn't that great? And those who can't, well, the government will pick up. That actually is a model which does not work well because it's very, very inequitable. And this is the challenge that we face in New Zealand, is that our health system is deeply inequitable. So people of lower socioeconomic status are going to have much less access to healthcare than those who can afford to pay or who have health insurance. It's geographical as well, by ethnicity as well.
Underneath all of this is a health system that has been seriously underfunded for a long time, experts say. And New Zealand's not the only place experiencing a health crisis. But compared with other leading countries, we're hurting more, according to the Commonwealth Fund, which compares the health system of the top countries.
New Zealand is the second to worst performer out of the about 10 countries that the Commonwealth Fund routinely compare. We were about the second worst on equity, which is a really, really bad performance, given that we say that we are focused on equity and access to health services. Being only a bit better than the United States is really an indictment. Australia, interestingly, came out number one of all the health systems that they study. They've come out number one. And they also do, ironically, they do much better than us on equity in their healthcare system.
Our ranking in that, is it getting worse? Are there signs that, it's becoming even more inequitable?
I think it is. And that's because despite a long time focus on equity in the healthcare system, you're only going to be able to achieve equity if you actually have the kind of the levers within the system right. And we don't. We provide health services, we provide government funding. People will get patched up at the emergency department. They will be looked after to a certain degree. The United States, that won't happen, for example. You'll be patched up and just sent back onto the street if you can't pay. So it's pretty rough there. It's much rougher than it is here. But our system is not set up to deliver on equity, and this is the fundamental challenge. And all of the reforms that our governments seek to implement, the last lot was setting up the DHBs in the year 2000. Now we're a bit over 2 years into setting up Te Whatu Ora. a national health system. These reforms don't make any difference to the kinds of questions we're talking about here today, because we still have this set of underlying institutional arrangements which date back to a historic compromise made after the passing of the Social Security Act in 1938. That act was designed to, or intended to, set up a national health service where all health professionals would work for the health service, and that service would be free of charge and focused on delivering on equity and need in the community. It was to be set up in the same way in which our public schools are set up, that the teachers all work for the schools. If you want to go private, you can, but that's completely separate. If you work for a private school, you don't also work for a public school. Now, our health system has these unusual anomalies within it because of the historic compromise made after the passing of the 1938 Social Security Act between the medical profession and the government at the time. The medical profession was very resistant to sort of being nationalised and to working for a national health service. And so the government agreed that GPs could continue to own their own practices and charge patients. They would also get a subsidy from the government. And it was agreed that in the public hospital system, any doctor could also have a private practice. And that's how things work today. It's a deeply inequitable and sort of incongruous set of arrangements, really.
But what is actually wrong with that arrangement, Robin?
What's wrong with it is that if you're concerned with equity, you're not going to be able to achieve that, because you're always going to have unequal access for those who are better off or have insurance to the private sector. Unless we do something fundamental about how we fund our healthcare system, how we fund care, then we're not going to be able to achieve equity. And that's another pretty interesting question, is the how we fund question, because to me, it's how we would be able to deal with the equity question with those institutional arrangements which I've just been describing. And politically undoing those institutional arrangements it's in the really, really, really hard basket. It's probably not possible to do much about them.
And so what you're saying is that GPs will continue to be private providers and will continue to have this mix of surgeons who can operate in the public and the private system, that kind of thing.
Yes, I think the GPs, there is a kind of a generational evolution in process, and younger doctors now don't necessarily want to own a practice. They don't necessarily want to work on a fee-for-service basis. Many of them would be quite happy with a salary. So there is a kind of a gradual transition going on where eventually we may find a government that has a mechanism for building the budget to the extent that they could fully fund general practice and take away the fee-for-service that sits there at the moment, ideally. But then the public-private mix in specialist care is also quite complicated, and undoing that would be politically quite difficult. It's very, very complex. I mean, these are good doctors. We need them. When you start to say, actually, you should all work for the public service and we're going to eradicate your private business, some of them would probably start to say, I'm not going to live in New Zealand anymore. I'll go elsewhere where I can make a decent income. You can't blame them for that. It makes it very financially beneficial for specialists to also have a private practice. And they will say that they are very committed to the public sector work as well. So it's complicated.
You've written about a different way of funding health in this article in The Conversation that would be similar to the kind of system in Germany or Denmark, where the health providers are largely private, but there's a kind of a social insurance system like ACC.
That's right. And this requires a lot of analysis. But in fact, there's a growing number of reasonably influential people in the country who agree with this line of thinking, that we should be starting to look at how we set up a social insurance funding model for healthcare in New Zealand. It's basically what ACC does. ACC collects levies from employers and employees, and then it provides accident and injury coverage and compensation. So a social insurance funding mechanism for health would be very, very similar. Countries that have social insurance, there tends to be a reasonably strong role of government in there to ensure that those who can't pay, there is a contribution coming in for them. But what social insurance does, very, very importantly, is it provides for equity. it solves the equity problem. And so Germany, Japan, Taiwan, Korea, I mean, these are all parts of the world with social insurance. What's really important about social insurance is that no matter who you are, no matter what your income is, where you live and so forth, what ethnicity you are, you get exactly the same level of coverage and payout as anyone else. And so when it comes to the provision of services, it's agnostic of provider, very importantly. So you think about the public and the private, it wouldn't matter. We're a specialist, public or private, because no matter who they see, whether it's a person of very limited income or someone who's a multi-millionaire with all the private insurance in the world, they're still going to get the same level of payment coming from the social insurance system. So they can have a public and a private practice, and that's how ACC works. ACC will refer patients to whomever is going to provide the service on contract to them.
Does that mean that we would be paying more in tax?
Not necessarily, no, because the level of income tax should drop because the tax-based sort of health funding system would disappear. It would mostly disappear. There would probably still be a need for some health tax to come in to ensure that the government's able to provide for those who are not able to pay in through their employment into social insurance. But then it would be compensated for with a new levy coming out of your pay packet, as ACC does.
How difficult or easy would it be to change to this system?
I think it would take political will, a government very committed, and this would be a long-term project. It would not happen overnight, but it would be a bit like probably setting up the NZ Super Fund. So there would be a need for the government to come up with quite a substantial sum of money to get the social insurance system going. There may be a transitional period of time of a few years where they work to build up the social insurance fund and then build up the mechanisms for costing out how much certain procedures require in terms of funding from social insurance, and then working out how to pay the various providers. It's not perfect, but the one thing social insurance does do is it solves the equity problem.
If we stick to the current model, what's the future? Will it mean there'll be further privatisation of our health services? Will be more people be signing up for health insurance? I mean, Victor Luca thinks that we're heading towards the US system.
I think there is a kind of a gradual creep towards the privatisation. I understand the number of public hospital specialists working privately has been going up as well. I think it may now be over 50%. Historically, it's been sort of 40% or so. And I understand now it's sort of 50% or so of specialists also holding a private practice. So you've got that creep going on, and that will be because of demand, sometimes frustration with working in the public system. And then, of course, you've got people taking up insurance because of fear that the public system is not going to be there for them when they most need it, especially in the context of something like cancer, which strikes absolute fear into people's hearts, or anything as simple as, will I get the hip joint replacement that I might need one day? So there probably is a gradual sort of creep towards privatisation going on. To go in the US direction, you would actually have to have the government sort of almost explicitly pulling out of the public sector and saying, we're only going to do certain things. And if you want other things, you're going to have to go privately for them. So that, again, politically would be quite difficult. But what we're going to have, I think, is ongoing struggles with delivering on equity. We're going to have ongoing failure in our healthcare system to care often for the people who are most in need, those who are the worst off in society and most in need, especially Māori and Pacific people and others who we just know the system does not deliver for all sorts of reasons.
That's it for today. I'm Sharon Brett-Kelly. The Detail is a newsroom production supported by RNZ and NZ On Air. This episode was produced by Gwen McClure and engineered by Phil Benge. Thanks to Victor Luca and Robin Gould. Mā te wā.